So we promise a lot of pyrotechnics to finish. Okay, so the question is combination necessary if you use anti-TNF? And when we speak about combination therapy, presumably we are talking about combination consisting of an anti-TNF agent rather than other biologics, plus an immunosuppressant, and that may be a thiopurine or it may be methotrexate. And then we're talking, of course, about Crohn's disease versus ulcerative colitis. And then we're talking about maintenance, induction versus maintenance, and then how long during maintenance. So this is a very complicated question depending on what setting we're talking about. Induction, maintenance, which disease, which immunomodulator, et cetera. And I think, of course, necessary is an absolute term. But I think the most important lesson that I learned or reinforced after preparing for this talk is that the one solid statement that we can make, in my opinion, is that combination therapy is favored over anti-TNF monotherapy in the induction of remission in most patients with active Crohn's disease or ulcerative colitis. So I'm not talking about maintenance. Okay, there's debate there. But I think in the short term, if you're talking about the optimal therapy for induction, the optimal therapy is combination therapy. So let's talk about the data on Crohn's disease first, and then the data on ulcerative colitis, and we're going to break it down for induction and maintenance. So Crohn's disease induction, SONIC study, clinical remission, combination was better than infliximab monotherapy. When you looked at 26 weeks, which was the primary endpoint, and if you look at the extension to 50 weeks, again, combination therapy was superior to monotherapy any way you look at those patients who entered the extension study. And moreover, there was a much higher rate of endoscopic healing in the combination arm, and a markedly lower incidence of antibodies to infliximab, which, as we know, predict loss of response. And correspondingly, there were higher median trough levels for infliximab. And, the price, you didn't have to pay an extra price for this, okay? The rates of infections were serious. The rates of serious infections were the same. And nobody's going to speak about the risk of lymphoma at week 26 or 52. So again, in this short-term study of 26 weeks and with the extension to 50, combination therapy was favored. And moreover, the superiority or the incremental benefit of combination therapy in this post-hoc analysis was greater in patients who had got a little confused here. These were data looking at patients who had ulcerations at baseline. Again, endoscopic healing is higher in the combination arm, CRP normalization higher, the combo higher. And these benefits are even greater in patients who have disease that is newer, of shorter duration. I mentioned the REACH study. This was a study that compared 2 arms of infliximab every 8 weeks and every 12 weeks in children who responded to infliximab induction. And I'm not presenting you the comparison between the 2 different arms. The point of this is to say that in this study, where patients were required to have been on an immunomodulator, all of these children were, had moderate to severe disease, and they had to have been on an immunomodulator for at least 8 weeks before the study. This study demonstrated tremendous rates of clinical response and clinical remission at week 10 and at week 50. Granted, we don't have any data on endoscopic healing, but again, I think looking at these numbers, they're really at the far end of the spectrum in terms of positive outcome. This was the COMMIT study. Again, continuing on the theme now of changing an immunomodulator from thiopurine to methotrexate, these were patients with active Crohn's disease who were receiving prednisone induction therapy, and they were randomized either to methotrexate plus infliximab or methotrexate alone, or infliximab alone. So it is true that there was no difference in the rates of treatment failure at the end of the study, which was at week 50, but again, the co-therapy with methotrexate significantly reduced antibodies to infliximab, and media trough levels were much higher in the combination arm. So yes, there was no difference at week 50. But again, you sort of think to yourself, if this is the difference in the rate of formation of antibodies to infliximab, this five-fold difference, and if antibodies to infliximab predict loss of response, then you anticipate that in the longer term you would see those two different treatment approaches diverge in terms of outcomes. This was an open label study from Japan, where they compared adalimumab alone versus adalimumab plus very low dose azathioprine. No differences in remission, but much better endoscopic improvement in the combination arm. So how do I put together all this information from the induction studies for Crohn's disease? As the SONIC study showed us, combination therapy is superior to monotherapy in inducing clinical remission, inducing mucosal healing, and moreover, inducing this deep remission, or at least endoscopic plus biochemical remission in early onset disease. I think the data are very consistent that immunomodulators reduce the formation of antibodies for both infliximab and adalimumab. And moreover, we have more data for infliximab in terms of co-therapy improving infliximab concentrations. So let's look at the data now for maintenance, which I think are fewer. So the best study is the Van Asch study. So these were patients who had well-controlled Crohn's disease for at least 6 months after the start of combination therapy with infliximab and immunosuppressant. And these patients have to have started again, have to have been failing an immunosuppressant when they started the anti-TNF. So these patients, again, had moderate to severe disease. They started on an immunosuppressant. Later on, they had the addition of infliximab, and then they were randomized after they had been stable for 6 months to either continued immunosuppression or withdrawal of the immunosuppression. Now, remind you again that this was an open label study, and the primary endpoint was the proportion of patients who required a decrease in infliximab dosing interval or stop therapy, and there were various secondary endpoints. So again, there was no difference in the clinical outcome. Basically, the proportion of patients that required a change in their infliximab therapy, but again, the study group that continued on the immunosuppressant had a lower CRP than the study group that stopped the immunosuppressant. And again, the infliximab trough levels were higher, 2.9 in the immunosuppressant group, and lower in the group that discontinued the immunosuppressants. And if you remember the previous speakers, Ed mentioned it, is that very low levels or absent levels of the anti-TNF predict the development of ATIs and eventually loss of response. So whenever we allow our patients to sort of, speaking of de-escalation, whenever we allow our patients to drop to undetectable levels, we're going to promote immunogenicity. So, and this is a graphic of what happens to the CRP levels and the trough infliximab levels in the two arms of the study. So the discontinuation arm had consistently higher levels of CRP, and the continued immunosuppressants had consistently higher levels of infliximab. Moreover, back to the point of losing completely detectable drug in the circulation, you see here that a significant percentage of patients who discontinued the immunosuppressant ended up having undetectable trough level. This is a study that is just is an abstract in this year's DDW. These were 3 cohorts, patients who continued infliximab plus azathioprine, patients who had their azathioprine dose halved, and patients who had their azathioprine dose stopped altogether. The patients who stopped had higher treatment failures at 1 year, although that didn't reach statistical significance. But again, they had an unfavorable development in their pharmacokinetics in terms of developing much lower trough infliximab concentrations. This is a study from the pediatric literature where they showed that concomitant therapy with an immunomodulator for at least 6 months was associated with much higher rates of infliximab persistence compared to treatment with immunosuppressant for 6 months or less, or no treatment at all. And when they looked at the boys, because they didn't give methotrexate to girls, when they looked at their children that were, at their boys that received methotrexate, they found that boys that were treated with methotrexate plus infliximab had an incredible persistence of therapy versus kids that did not. So again, the way I synthesize this is that combination therapy is associated with a lower frequency of antibodies to the anti-TNF agent, more favorable pharmacokinetics, higher trough concentrations, and however, in contrast to the induction studies, there is no proven benefit to combination therapy in the maintenance setting, okay? In the maintenance setting, not the induction setting. Of course, the big elephant in the room is the development of heterosplenic T-cell lymphoma. Has anyone here, putting aside Ed or Marla, who work at really world-renowned tertiary centers, ever encountered hepatosplenic T-cell lymphoma? You have, okay. You know, the estimates, and again, to estimate a very, very rare event, the confidence interval is extreme. This was by a review article by Laurent Bourgerie, and he estimated that the risk is 1 in 10,000 male patients, so extremely low risk. Yes, the risk of EBV-associated post-transplant-like lymphoma is increased, but again, the absolute risk of lymphoma in our young patient population is 1 in 10,000 per year. So sure, you know, depending on what study you look at, yes, this risk does go up. And again, this is the French study, very high risk, the highest we've seen. Usually we see it 3 to 4-fold higher. And this is the Kaiser study. They saw only a 1.4-fold increase. But having said that, it's clear that combination therapy increases this risk further. But again, the point is you take a very small number, yeah, you may multiply it by 3 or 4 or 5, it's still an extremely small number. And the bigger elephant in the room is the loss of response. We know that patients lose response to the anti-TNF at a rate of 20% per year in the first couple of years. Yes, it plateaus after 3, 4, 5 years and there's no further loss of response. But I think this is a big opportunity for practice improvement, in my opinion. So don't take it from me. Again, this is in your syllabus. The AGA gives a weak recommendation. So it suggests combination therapy over monotherapy for induction. Again, we have to take into account patient preferences. And it makes no recommendation, again, reflecting the maintenance data on the relative strength of combination therapy versus monotherapy for Crohn's disease in the maintenance setting. Now let's move to ulcerative colitis, data on induction, combination therapy in the study by Remo. Clearly, by various different measures, the primary outcome, endoscopic healing, patients with normal fecal calprotectins, the combination therapy was superior. This is the only study I could find. This was a retrospective study from the University of Chicago where they looked at persistence of therapy at 1 year, and patients with combination therapy, again, tended to stay on therapy for longer, reflecting effective therapy, presumably, had higher concentration, trough concentrations, and moreover had much fewer antibodies to infliximab. So the way I synthesize the data on ulcerative colitis, for induction, again, combination therapy is superior to monotherapy, and there are no good data for maintenance. And these conclusions are, have been taken up also by various recent consensus groups that have come together. The AGA hasn't done this yet, but a Canadian group, the Toronto Consensus, also recommended combination therapy over monotherapy to induce complete remission in ulcerative colitis. And similarly, the ECHO, the European Crohn's and Colitis Foundation, actually was even more aggressive in its recommendation for combination therapy, not only in the inductive phase of treatment, but also in the maintenance phase of treatment. So my conclusions are that combination therapy achieves better induction outcomes in both Crohn's disease and ulcerative colitis. The outcomes, efficacy outcomes are better, infections are the same, and you'll all agree with me that over the period of 6 months, there's no difference in the risk of lymphoma, okay? The second major conclusion is that concomitant immunosuppressants reduce antibodies to the anti-TNF, and that may translate to lower rates of loss of response and failure. And so I think you should consider combination therapy in most patients, and particularly in those who develop antibodies to one anti-TNF drug and then move on to the next one. I will concede that there is a risk of lymphoma, which I think we have blown out of proportion. But if you're worried about that, then that's fine. You have an alternative, and that is to use methotrexate. And in fact, the data from that pediatric study showed that not only, in this kind of setting, methotrexate, not only will it not be associated with a risk of lymphoma, but it actually may, at least in that study, performed better than the thiopurine in maintaining, leading to higher rates of persistence of infliximab therapy. Thank you for your time.